and I'm a family physician. I'm cohort 11. Yay, cohort 11. And I'm semi-retired now, but before that, I was in the FQHC world, medical director of several um, FQHCs, and also medical director at a Medi-Cal managed care organization in the Central Coast. And first, I want to thank everybody for sticking with us. Uh, Friday afternoon. Congratulations. You must all be really exhausted, including our distinguished panelists. Thank you so much for being here at 3 p.m. on a Friday afternoon. This session is going to be about an hour long, and wanted to first set the session up with what we've seen the last 2 days. There's going to be moderated questions where I ask the panelists. There will be an audience Q&A section in the last 10-15 minutes, as well as some closing sessions. So that this is how the hour is going to be. And then I think there's one final session at 4 o'clock. So for the last 2 days, we've been discussing and thinking about how to care for ourselves and our teams as healthcare leaders and as healers, and about how to heal our broken systems and focused on inclusion and belonging. We started yesterday with Dr. Sobel talking about stress and resilience, moved to David Katz talking about resilience and battle buddies. We heard some great model from Jennifer Carden-Wade on Laguna Honda on wellness and concrete things that they've actually done to bring it into their organization. Then we did the social media workshop. And then today we had some really, really powerful and meaningful presentations. First with Dwayne Reynolds, of course, doing a session on belonging and really shining the light on inclusion, unconscious bias, and institutional racism, and how to become an inclusive leader in your organizations. We went on to hear from Josh and Brent on health equity and integrating theater arts, the theater of the oppressed. And then we also had some really meaningful, difficult breakout sessions with Jay and Pooja. And today, right now, we are really thrilled to have Kim McCoy-Wade and Kris Perry here to talk about how California in its statewide efforts is thinking about and acting on healing our broken healthcare system and how to care for our more vulnerable population. So we have today Kris Perry, who is Deputy Secretary and Senior Advisor to the Governor on Early Childhood Health. She's going to be sharing information and policy about our youngest. And then we have Kim McCoy-Wade, who is the director at the California Department of Aging, who will be sharing about older adults. So again, thank you so much for being here today. And Kris, you have a plan for early childhood education through the governor. Can you tell us a little bit about the master plan for pediatrics?
I sure can. Hi, everybody. Nice to see you again. It's been a couple of years, and I'm so happy to be here with my good friend and colleague, Kim McCoy-Wade, who has lots of exciting news to share on her master plan of aging. So let me just kick us off with the front end of the lifespan and talk a little bit about early learning and development. When I saw you last, we were just kicking off a process of planning for the next 10 years so that by 2030, the state of California is doing far more than we're currently doing. We're doing quite a bit right now, but far more than we're doing right now to deliver an integrated, comprehensive set of health benefits to children birth to 5, and in particular, children prenatal to 3, as well as how we're going to move our care system, which we know from the COVID pandemic has been very tested and is far more fragile than maybe we even realized, to be more equitable and deliver higher impact and better outcomes. And we do that through really just a couple of sort of what might call sort of high-level strategies, and to ensure that we give children an equitable early learning experience. And that really comes from the most obvious common sense things you can imagine: direct support to parents and families, which we're starting to see with our partners at the federal level, new tax credits, new supports for families that are low income to be able to take their children to high quality care, as well as transportation and housing supports. In other words, really focusing on family and child poverty as a solution to early childhood development, as a way to improve that. We also know that we have to bring better and higher quality services to children, and those are the full gamut between health and education. Since you are all health professionals and experts, you know better than anyone else how important that pediatric setting is for having conversations with parents about everything related to their child's development, whether it's their health, education, behavior, all of it, all of the caregiving that goes on in a child's life. And then finally, the workforce. And when we talk about workforce in the early childhood space, we're primarily talking about teachers and caregivers, where you take children when you're working yourself or you have other commitments. And what we know we have to do in California and across the country is for the first time ever, think of the women, primarily women, Black and brown women, who are providing this essential service to essential workers and to all of us, as a profession, and one that is worthy of a livable wage, benefits, and other security, so that they are able to provide that high quality early childhood experience that we know highly correlates with lifelong learning and success over time. So the master plan, finally done in December, gives many, many details about how we would achieve that greater investment in the workforce, greater investment in the family, and overall how we would support the system to get to to be better than we are today. And I'll talk more about those details after you hear from Kim, and we can compare and contrast where we landed in our plans.
Perfect. Kim, can you tell us a little bit about the master plan for aging?
Yeah, there's lots of ways that we're very similar, and there's actually a lot of ways we're pretty different. And so I think that's super interesting. And we very much, I'll just say from the beginning, I think both rejected the children versus adults framing, and we're all in the same families. We're all gonna hopefully go through all these stages. So we really have come at it from a whole family, whole community approach, and the kinds of things that people need that oftentimes that what works well when you're 8 also works well when you're 80. And vice versa. So we really tried to keep that whole lens. But the master plan for aging came out of a real realization that the governor had in 2019 that aging was really changing, and that in short, we were not ready. What do I mean? We're all living longer. California has some of the longest life expectancy. I hope you all are now planning for your 70s, 80s, 90s, and 100s. Got your plan ready, your own personal master plan? Your parents, do your children? How many generations are in your house? I just lost our 4th generation in my family, but I have peers with 5 generations, and there's lots of that happening. So we're living longer. We're also, and Kris knows this well, by 2030, there'll be more people over 60 than under 18 for the first time. So that changes how you think about your community, your housing, your parks, your healthcare. Why is pediatrics a norm and geriatrics a specialty if there's more people needing geriatric services than pediatrics? So things like that, like, again, not to be competitive, but to be reflective of who are you serving. And then, of course, aging is diversifying. Unlike young children, we are still majority white in California at the older age of the spectrum, but that is changing rapidly too. And it's diversifying differently. So for example, we've got about a quarter of older adults speaking a language other than English at home, but there's no number one. There's a whole mix of languages. So we're having some challenges programmatically thinking through how we deliver multiple languages. There's no sort of clear number 2 like there is, I think, with young children, and Kris, correct me, where English and Spanish tends to be the way you roll. We pretty quickly get to Mandarin and Cantonese and other API languages and need to do better. So aging is changing and we're not ready. That was 2019. Well, guess what happened in 2020 in terms of 2020 vision, in terms of COVID? And I think COVID, I don't have to tell this group, and again, there's no Olympics on who suffered worst in COVID. We all suffered in different ways in different boats. But the experience of older adults, some of the ways that it was traumatic and deadly, obviously, are the fatality rate. Older adults died. Majority of deaths are in older adults, and the majority are in congregate care. So we've got to really look at what's happening in our congregate facilities. More and more older adults now want to live at home, but does that mean to be isolated and not have connection to humans, to not have connection to the internet? How is your food getting? What if you don't drive? So we really, if we're going to commit to all of us living in the houses we want to live in, as we go through that third of our life, that fourth of our life, how do we make that work? So, and then in between, actually right before COVID, the other big thing that happened in our process was our stakeholders came together and said, you know, it's nice that you have equity in your values and vision, but we want to see it in the work. And so we're calling on you to form a new committee, the Equity Work Group Committee. And I will say I had a moment of, we already had 100 stakeholders engaged in multiple subcommittees, a full cabinet work group, but it was obviously the right thing to do. And so we created an equity work group that began meeting and had met a couple times before COVID started and became our equity advisory group during COVID. But more than that, they produced an equity tool with 6 questions that any recommendation had to be kind of processed through to kind of go through an equity lens. They also really made sure, and I'll talk about more as what the product was that came out in January, how, in the words of our stakeholder and commissioner, former Assembly member Cheryl Brown, equity was baked in. This was our metaphor. We're not sprinkling in at the top, the very end, your rainbow sprinkles. It is baked in at the very beginning. And so we hope we achieve that goal. In January, we released it with the secretary and all cabinet and legislative and stakeholder members. We set 5 bold goals for 2030. And all of them have equity baked in some way or another. 1 is more housing for all ages and stages. 2 is transforming health. And here the goal specifically calls out the differences in life expectancy in California. And while we have the highest overall, we have tremendous differences across race and gender. So how do we increase life expectancy and close the gap? 3rd was inclusion and equity. We have a huge problem with older adults being excluded, isolated, ageism, elder abuse. How do we reintegrate cross-generation? This is where Kris and I had some of our best conversations. So it's not senior centers and childcare centers, it's community centers, right? One of my favorite places to visit was the dementia care center that was on site with the preschool and the combined music class, right? So like how do we make the playgrounds and the parks and the community spaces work for all of us? Our workplaces work for all of us. Yes. So lots of great equity work on that. The 4th was caregiving that works, family caregiving, paid caregiving, virtual caregiving. And the 5th is affording aging. Again, huge equity gap in people's ability to pay for those bonus years, Social Security, pension, and of course, your asset of your house. So equity was baked in many of the ways there. We built a new data dashboard for aging with our public health colleagues that has kind of your one-stop portal for all of our goals and initiatives and metrics. We put up what we had. So for example, we have pretty good county data. Then the next best, I would say, is race data. We do not have enough LGBTQ data. We're going to do our first baseline of that in the next month. And then disability data is far behind. And there's much more we need to do to add on that side. And then we also included a local playbook to help increase the local leaders, because we have 3 county master plans for aging, but our not so secret goal is we want 58. So 3 down, 55 to go. Credit to LA, San Diego, and San Francisco. And then the last thing I'll say that we did to make sure our plan wasn't just a plan that stayed on the shelf was the whole cabinet signed off on 132 initiatives to do these 2 years. So for 21-22, we have an initiative work plan of 132 initiatives that people are tackling in partnership with the legislature, with stakeholders, with philanthropy, local government to get done. And so that's been a real accelerator. And some of those are specific about equity, whether it's language access, equity trainings, inclusion of family of choice and family leave, things like that, that we wanted to lift up as things we knew we could move forward in the next couple years, not couple months, couple years. So let me just stop there. That was probably more than you wanted, but that was kind of where we started with, that's where we got to in January when we released it, and now we're implementing.
Sure, that's an amazing summary. I actually have one clarifying question, and then love to go back to Kris. The equity work group committee that you were talking about, was that specifically in the California Department of Aging, or is it statewide in all the departments?
So for the purpose, the master plan itself was under the auspices of the Secretary and Department of Health and Human Services. The Department of Aging was charged to run it. So we ran all of those committees on behalf of the Secretary, including surprise, surprise, we recommended that the Equity and Aging Committee continue. And so that is actually the only committee we've convened so far to launch, the first one to convene, and they are kind of reforming. They are going to be housed at CDA, but this is what I love about my department. Like Kris, I'm about a person, not about programs. So we see our role very much as advising every department and supporting every department in that, whether again it's Parks and Rec or Food and Ag or housing, we want aging to be on their agenda and we want to help them do that. So we will staff the committee, but I'm looking at an agenda and we're bringing in 3 secretaries to talk about their issues and how we can make sure older adults are both layered in multi-generationally, but also targeted when the needs are specific.
Great, great. And Kris, could you tell us a little bit about both the similarities and then also some of the unique challenges of working with our younger population, our younger vulnerable population?
Yeah, happy to. I mean, I love that example of a community center where the different population groups are together and building on each other's strengths. I think that is a transformative idea. I love it. I'll never forget being at my computer at probably month 3 or 4 of the pandemic, and Kim sent me an article from, was it Finland, where they have foster grandparents who live far away from their own children, because people like in just the United States, we grow up someplace and we move away. That the aging population there was adopting preschools or childcare centers in their neighborhood, and they were beloved. They would come for their daily or weekly reading, circle time appointment, and the whole class would just, they were like groupies. So I love the idea of California moving more in this direction. What's been hard about the pandemic is what a tremendous barrier that has been to greater integration, and we'll have to keep figuring out creative ways to avoid too much of that. Places where we have a lot in common, funding. We, in the plan, talk a lot about how underfunded, under-resourced little kid care and development and support is. And I think the same could be said for older Californians, that we have not invested heavily in senior centers, senior activities, aging activities, the integration of older Californians into all kinds of parts of our community. So they're both going to require some additional investment. We could probably look at public-private partnerships and other ways to to build creative solutions to this. And programs. So in early childhood, mostly we're talking about the care of children. And there's a health aspect to this, right? Pediatrics, geriatrics. I think that this is an area where we just need more providers, home visitors, people that understand that developmental stage and the risks and some of the different developmental assessments, risk assessments, trauma assessments, different ways that we can get under the hood and understand better how people are really doing. And then finally, I'd say we love data too. So in the early childhood space, we are woefully behind the real world. And when it comes to data, understanding who's in California, where they are, what they need, where they're going, who they're with. We have really, really limited data, and it makes it hard to target these precious resources at the kids who need them the very most. And it's like it has made policy and strategic decision making quite difficult. But I will say, on a happier note, with the new federal funding coming to California through rescue, relief, and infrastructure, there are new opportunities to build our system better. and really put a stop to the sort of the she-cession that we have right now, because we know that the early care and learning field, and I would venture to say the caregivers for older folks tend to be Black and brown women, and they are underpaid, and they are at high risk of all kinds of difficult things that happen in these workplaces because it's a very physical job. We as a country, and hopefully as a state, will continue to invest in their safety, their well-being, and their wages. And I think that's, that there are some real parallels here. These are slightly vulnerable populations,
Yes.
right? In the sense that they live, they aren't necessarily in the sort of the tax earning voting age group, and so they have less of a voice. So I'd say finally that's one other area of similarity.
Yeah, I have to let you know that our fellows are incredibly engaged. They're just shooting these questions, and I'm not ignoring them. I will share them in a little bit. I just wanted to ask a couple of questions. A lot of our fellows either work for community health centers or community health organizations, hospitals, et cetera. And, when you mention funding, everybody's ears always kind of perk up. And I just wondered, under incentives, state incentives, metrics is also something that, of course, many of our organizations really our funding is dependent on meeting particular metrics. Are there any new incentives or metrics that you see coming out and being pushed out to community health centers, hospitals, other health organizations? And maybe I'll start with Kim and then go on to Kris.
Sure. So Kris and I sometimes joke, the system she's got to tango with is education. The system I get to tango with is health. Not that they aren't important, but health is pretty important in older adults. And frankly, a lot of our, as you all well know, there's a lot of money. I mean, you can always use more, but there's plenty of money. Is it going for the right things in the right place, right? So, the very alive conversation right now about nursing home, balancing expenses between nursing home and home care, right? So what we're looking at in California to take long-term services and supports and move them statewide through the CalAIM process is a huge opportunity for equity that everybody could, you got to be able to afford your home, but then live at home with care that works for you. So I think as the money and the metrics get balanced from institutional care to community care, that's a big one. I have to say, I'd be remiss if I didn't lift up something that I'm super excited about, which is the geriatric ED movement in California to certify EDs, emergency departments as geriatric, which is about people and processes. And so I was meeting with California hospitals yesterday and hearing about this more. And so the story they tell, right, is the older adult who presents with a broken wrist. This is a very typical thing that happens in an emergency room, she's with a broken wrist. And the ER can set that wrist, check for head injury, and send you home pretty quick. That's what ERs do, bread and butter. But what a geriatric ED would do those things, but then would also say, why'd you fall, right? Let's look and see, do you have multiple medications that are causing dizziness? Do you have some home safety modifications that we could screen for and check? Are you able to go home safely? Nutrition, was it a blood sugar issue? Can we do some of that whole screening, social work screening? Maybe not admit you. Maybe we don't have to admit you for observation because we know you can go home safely and prevent the broken hip 3 months from now, right? So I think it's kind of, how can we do that? That's not even that upstream. We're already in the ED, but we're taking that moment to say, and I didn't even go to, did somebody push you, right? There's a lot of reasons people fall. And so that kind of, and it was so exciting was the people who were at the bronze level, they called it, who didn't even spend that much money to kind of train people and screen people and have the social worker come downstairs to the ED as opposed to waiting till you get admitted for the night, and got some bed rails put up so you didn't fall again in the ED. So there was a really kind of easy interventions that had really profound if you're measuring the right thing. So I think there are some light geriatric training so folks know how to look at multiple meds, right? That's one of our big issues is probably not so much of a kid's issue, is how many prescriptions you show up with, a dozen scripts, right? And how they interact from maybe 6 different doctors. So I think there's a lot of opportunity in, the time frame you're measuring, the outcomes you're measuring, the losses, how you count for things that didn't happen, that I think are really exciting in Medicaid. And I would just be remiss if I didn't say we're also hoping to figure this out in Medicare. Governor's office proposed a new Office of Medicare Innovation and Integration. And everyone always goes, oh, that's a federal program. There's not much you can do. But a few states are figuring out what you can do with Medicare Advantage and other, Medicare Advantage is how Medicare folks pay for dental care. It'd be great if everybody who's older 65 got dental care, either through Medicaid or Medicare. So I think there's a lot that we can do with the dollars we have, which is not to say that we don't need more dollars, but that the dollars we have in the right place at the right time with the right care circle. And I can't believe I didn't say to this group, assessing the family caregiver, right? Too, how's the family caregiver doing while you're there? Are they stressed? Are they out of town? Like, what's going on with the family that this happened? All of that, I think, is where a lot of potential and opportunity is right in our fingertips. And the feds are only about to help us do even more.
Great, thank you. Kris, anything you'd like to add?
Yeah, I did want to add one other kind of interesting innovation that came out it's been over a year now. I noticed there was a question in the chat, and I also wanted to flag when I mentioned trauma and developmental screening that we have been providing a value-based payment to providers now for over a year to screen for developmental screen and trauma screen kids when they come in. And we're doing what we can to understand what the scores are. It's a little tricky, because of privacy, obviously, but also, we have back to data systems and what we do and don't collect. But what's really important here, I think, is to, in the analogy with aging is to get more and more information about children and adults when they come in, so that we're treating the right thing, and we're making the right referrals, and we're following up on that which might be chronic or of greater concern. And those value-based payments have been a kind of a great innovation for us in terms of getting that additional data and lens into how kids are doing. And then I'd also be remiss if I didn't say that even with that, and now with the pandemic, there is so much pent-up demand, and there is so much concern about how kids are doing. And parents, many of you are probably home with your kids right now. I think Kim is. And this is so stressful, and now schools are beginning to reopen, but we now know from reduced rates of child abuse reporting, maybe elder abuse reporting, that there will be there's another pandemic, that of depression, isolation, abuse that we're bracing for. And I think even these assessments will not adequately identify the need. And so we're bracing for teachers, nurses, and other providers to be alerting the system that there are issues with families. And finally, to channel the Surgeon General momentarily here and her work on ACEs prevention and is back to assets and strengths, is that parents can really buffer these stressors for kids. If they're in a good place, they can buffer some of the negative impacts of this pandemic and other stressors on kids, and those outcomes or those impacts could be felt for a lifetime. And so we really are excited about some of the public education work that's going on with ACEs Aware, with Cal Hope. There are other campaigns within the First Five world, all of which are really trying to say to parents, hold on, we think that you're making a big difference, even if you feel terrible, but they need a lot of support. So I think, we even if we're just looking at young kids or older Californians, caregivers, family members, and others that have been trying to keep it all together and keep everybody going are also under a huge amount of stress. And we don't have easy answers to that.
Right. I know that there are, again, a lot of questions and comments around equity, and I may have, Renee kind of look through those and summarize them in a moment. But before we jump into it, before COVID-19 hit, CalAIM was something that the state was spending a lot of time. And I would like to say that even as COVID has hit, there are still efforts occurring through CalAIM. I think probably our audience would be really interested to hear where the CalAIM effort is right now. Maybe a little bit more about care coordination, aging in place versus institutionalizing, social services for aging. Kim, could you talk to us a little bit about where you think it's at?
Sure, I will try to be brief and also accurate because so much is happening. I mean, I would say the short version is full steam ahead. CalAIM is back on, which of course has many pieces, but moving to a managed, statewide managed care, and in my world, managed statewide long-term services and supports, which is really, is also being discussed at the federal level now, is should that be a mandatory benefit in Medicaid, that is a national benefit. But certainly in California, we have the authority to go ahead and do that. That requires a serious look at our capacity and our assessment. Roadmap process is also being proposed. I mean, we don't have adult day health centers in every community. We don't have the multi-purpose senior program, which goes into the most vulnerable 80-plus-year-old folks' house to provide comprehensive care for folks. We don't have them. We don't, PACE, our gold medal integrated care program, still serving 10,000 people. I got 2 million who are on Medicare, Medicaid. So we got a long way to go between 10,000 and 2 million. So we have some policy issues with CalAIM and the feds on Medicaid and Medicare. We have some capacity issues on the field. And the roadmap is going to be really helpful. We're also looking at funding a statewide, I hate to be acronym speak, so I'm going to try my best. The Aging and Disability Resource Connection, or No Wrong Door, which is really meant to be that kind of first five. Who do you call when you need to have a question about aging or disability? But we really want to build the bridge deeper with health plans and with counties so that they can do that care coordination, and then be able to access the healthcare dollar for in lieu of services, which are two things that are getting baked into Medicaid, to the CalAIM proposal. What does that mean? It means that it would be allowed to be paid for someone to do the care coordination, whether not necessarily at the health plan, it could be at the nonprofit, it could be at the community group that has that cultural competence and cultural relevance and trust. And in lieu of service could be housing, could be nutrition, it could be that behavioral health, it can be all of these things that we know go into thriving. Yeah, I don't know if social determinants of health or in lieu of service is a worse mouthful for what we're talking about. Someone needs to figure out the driver of health inspirational phrase. But that's what it is, and this group all knows it. So, I mean, there's just so much opportunity. And again, the federal proposals around the FMAP increase, the 10% increase, just all kinds of dollars for one-time infrastructure. And then I'm very interested in what we're going to do with the caregiving opportunity. To Kris's point, it is caregiving economy, is adult and children. I think, Kris, we're further behind you in almost every way. I mean, I still think this issue that the childcare field has, I feel like you've shed the babysitting label and have professionalized and created that. And I still think adult personal care is not yet been certified and professionalized. And this conversation about a universal personal care worker and how that sets up her professionalism, respect, a wages increase, a ladder to home health, CNA, RN, we have a whole lot to do. It's our fastest growing workforce, and it's a terrible job right now in terms of pay and respect, and after COVID, safety. I mean, the deaths are unacceptable. And so we have just a huge responsibility and opportunity to get our arms around the caregiving workforce. And I think we do that in ways that align with childcare, but also recognize differences in the work as well.
Great.
I think I covered there's so much happening in Medicaid and Medicare. I'm sure I left something off and people can put it in the chat. There's just a lot happening. And that really is, we're reconvening as an agency, a community living advisory committee to focus on community living. It's been called Olmstead for the past 15 years and it's gotten a little sleepy. And so we're reinvigorating it. And we all agree the first thing we have to talk about is the opportunities in home and community-based services.
Great. Kris, anything you'd like to add?
No, I think Kim just did a great job when it comes to children's benefits and what's eligible under Medicaid. We are starting to take a much, much harder look at EPSDT and just how to be more comprehensive and integrated around children, the benefits children should be getting and taking advantage of. So like a value-based payment is kind of a standalone incentive. But we need to incorporate and integrate more of these efforts and make it easier for the provider to provide the care the child needs versus what is billable. So we're starting to really work harder on that, and stay tuned. Maybe next year I'll have something more specific to update you on.
Great, great. Well, I'd like to open this up now to some of our fellows who might have questions. So Renee, should I have our fellows unmute themselves, and or do you want to call on them? Or
yeah, I mean, I think if people want to raise their hands, that would be great. If people haven't asked a question today and feel like they have a burning question and want to raise their hand, that would be great. I know that some of the questions in the chat have already been answered live, so don't want to just go through the chat. And I see Susan Stone now has her hand up.
Can you hear me?
Yes, perfect.
Awesome, awesome. So I work at LA Care, and I am a palliative care and emergency medicine physician for many years. And I'm also kind of in this whole project for rolling out integrating palliative care into our long-term care facilities. And so here's my question. Oh, shut up. My dogs are barking. Sorry, right at the moment. Typical, right? So anyways, my question is, there are so many quality issues with long-term care, and there's a huge, the National Academy of Medicine has convened an expert panel to assess and review the lack of quality in these facilities. And as I work on CalAIM, I got all giggly looking at transition from long-term care back into the community, and I was dancing around, and I was like, wow, they have such a lobby and power and money in long-term care, some of these companies. And I'm wondering, I mean, I'm kind of like doing secret service work as I build out the community pieces. I work with them, but as I look at CalAIM, I'm not sure how we're going to tackle that piece of it. There's a lot of parts of CalAIM that we're working hard on, but this is one that just gives me pause because of their significant lobby. And I don't know if it's going to be how we pay them, or I'm not sure. I'd love to hear your thoughts.
Okay, well, I will. This is yes. Nobody can watch what happened. If you weren't already, nobody can watch what happened in the COVID and see that 40% of the deaths happened in nursing homes, assisted living, and not say, wait, is that the best we can do? So it's absolutely a fair question. Couple observations, and I guess you could probably tell by now, I spent the majority of my career in children's and families and came over to adults a couple of years ago. So I am constantly shocked by differences in the two. And we'll talk about child welfare and APS in a second, maybe. But right now, what I want to talk about is when I'm working, one of the things I discovered at the state, and this is for my policy wonk friends here, there is a huge shop of state people who regulate and license nursing home facilities. There is not a separate policy shop on what is the state's policy on nursing homes. Now, Kris, in childcare, those are two different worlds. Childcare policy is not the same as regulating the licensed childcare providers. It's informed by it, but what the state's vision on childcare. So I think we have this interesting place where we have an army of nursing home surveyors and regulators and data collectors. I run the long-term care ombudsman, which is sort of a residents' rights advocacy, kind of a CASA analogy program. DHCS is paying the bill, Lord knows, out of Medicaid. But that sense of what is our state's policy direction is both shared and therefore shared. I'll say that. And of course, there's other populations, whether they're people with developmental disabilities or other facilities. So there's a bit of a structural governance policy issue there. And then yes, anytime you're doing health and human services and there's a for-profit provider, it is a different dynamic. Again, child welfare, I'll just leave it there. And so I think how we kind of organize our policy shop so that we have a policy place that is not only the regulatory of the licensees, and how we also manage the fact that there is a lot of money being made. I'm heartened by what's happening in some other states in terms of, let's start with transparency. New York and New Jersey and other places are saying, where is the money that's being spent by Medicaid and Medicare in these facilities going? Is it going to staff? Is it going to care? Does it connect to care? Can we put that transparently? I don't know if anyone If you can watch John Oliver this week, John Oliver does long-term care, 22 minutes. It is not safe for work, so do it, or not safe for children. I can tell you from experience, but it is a great 22 minutes about how terrible long-term care is and how many opportunities there are to fix it. So we took some baby steps. We convened because we had to in the crisis, we convened a SNF advocate table during the disaster to hear from advocates and stakeholders every month. And actually it was weekly for a while, just problem solving, whether it was visitation or infection. And we did another one of geriatric expertise. We have so many geriatric experts from the UC system and otherwise. And so we now have quite a list of things to work on, but we are still, I'll be honest with you, getting organized about how to tackle it, much less the bigger issue of, the Veterans Administration federally said no more big nursing homes. They're all going to be small houses, and they're doing it. We tried in California a few years ago, and we got one built. We have another 1,000 to go. So we're trying to, how do we, like 10 years from now, think about earthquake retrofitting, how do 10 years from now, nobody's in a nursing home that's a massive institution. There are all these pods of 6 with a dedicated care worker, kitchen, living space, broadband. I mean, the Veterans Administration's doing it. California should be able to do it. So
Totally.
all of you join me in nursing home work. We need all of you.
I'm there for you. I'm there. I'm at least trying to get palliative care, and it's difficult. And I think you should have a daycare out back of the nursing facility too, because old people like kids.
Well, and that's what we heard during the pandemic, is that the older residents were actually like comforting and cheering up the workers.
Yeah.
Because of that resilience and perspective, that intergenerational conversation in the worst of times really was sustaining, even among the 20-somethings and the 80-somethings. So yeah, bring in the
Yeah.
always.
It has been done in other places where they give the residents a bird, they have a daycare. I mean, we can do better. So thank you.
Great, thank you. Other questions? So raise your hand. And I can't see all the hands being raised.
Yeah, we don't have any hands raised right now. Oh, I see Ann Lindsay has a question.
Ann Lindsay? You're mute.
Yeah,
She's right.
I'm glad to hear you mention. One is the whole process of aging in place makes me nervous, because it really is, aging in place is really lonely. As a family practitioner, I took care of a lot of old people who only people they interacted with were caretakers. So for them, that was a job. And what we have to build is aging in community. And there are good examples of the 2 for Life community in Brookline, Massachusetts, which has senior housing, but then they have community facility where there's activities that the neighbors come in and participate, so that, it's consciously bringing seniors in touch and together with the community. And, the small house project, you say you only got 1 pilot. Well, the word in the senior living community is that the application process was a bear.
Yeah.
And that the applications got lost. And so when are you going to actually make regulations and move beyond the pilot stage? That's
right. OSHPD had the regulations. That's exactly right. That's what we're trying to peel back now, is all the layers. I think actually every stage had a barrier. So it just didn't, we need a whole new redesign of it. So actually I'd love to follow up with you later to hear some of your diagnosis and user experience, but that's what we've heard too, is the regs, the fire inspection, the application, it wasn't workable. I will say, I hope I hope I didn't say aging in place. I try to never say it, because I agree with you. I think our entire part of the master plan for aging was a reimagination project, right? Everybody has such stereotypes and fixed thinking about aging. So basically when you say aging, people think 2 things: aging in place, sitting in your single family home that you bought when you were in your 30s or 40s and just stay in there, or nursing home. And those are like the 2 polar extremes of aging. There should be about a dozen other options in between that are affordable and integrated to your point with the community. So there's everything. You see this happening in San Diego with the streamlining of ADUs, trying to get ADUs everywhere. Part of that's about the affordable housing crunch, but part of that is living with your family, living with your caregiver. Either way, you start in the house, your kids in the back, then you flip. The caregiver doesn't have to commute an hour out to the eastern part of the county. They can live there, and you can subsidize their rent. So that's one model. We've also got naturally occurring retirement communities where there's a lot of older people living. Can LA Cares put the nurse on site there? like we're seeing in the Vermont SASH project and I Wish from HUD. Can we do adult family homes? I hate the word foster homes when it comes to adults, but are there families who'd be willing to take in 1 or 2 adults for a good rate to provide care and home? So a lot of things to do before you even get to assisted living and nursing. And we need to define that market, create that market, fund that market, make it attractive, affordable. But absolutely, we need a reimagination as much as the money.
I had a question
Thank
for both of you. I think in the past few years, Governor Newsom and state of California has really spearheaded a lot of initiatives almost on their own, certainly with little federal support in the past. And, movements with early childhood health care and aging. I'm wondering, now that we have a new federal administration in place, are there any new directions or initiatives that you're either waiting to hear or hearing about at the federal level that you see will need to be implemented at the state and then local levels?
Yep, there are a few, and not to toot our own horn here too much, but California has had, there are many things that the federal government is starting to act on.
Yes.
That were at least administered or implemented here, if not conceived of here. But let me start with one that I think is really relevant to both of the groups we're talking about today, which is paid family leave. That has emerged as a really critical policy area and an area that California has made great strides on, thanks to the governor. In just these past few years, we've extended the number of weeks that a caregiver can take paid family leave. And if you combine with another caregiver in your family, you've been, in some ways, right, you're stretching the leave from a family member by several weeks from where we were when he got there. Also, we've really done something to address wage replacement around paid family leave. Many low-wage workers cannot afford to use their paid family leave that they pay into. This is an insurance program that comes directly out of their paycheck. It is not a benefit from their employer. It is not paid for by the state. It's their insurance, all of our insurance. That it still wasn't meeting. It wasn't. They were netting less income, and so we've worked really hard to get that wage replacement there. That's something the federal government is already, the Congress and the White House are talking about actively right now, is improving paid family leave. It would do a lot, I think, with aging Californians as well. In addition to that, tax credits. As you know, the governor has been really vocal about earned income tax credits. This is another way of supporting in low income residents of our state. The federal government is also moving quickly. I know it's more advanced in the early childhood space on child tax credits, refundable child tax credits, and refundable child care tax credits. CTC and CCTC both are moving very well through well, are already been approved at the federal level, as well as those stimulus checks, which we know the governor has tried to do a few times, depending on different workforces or groups. And then last, I'd say where we're having a little bit of, I'd say, traction is around early childhood data systems. I think the work Kim has done on the data dashboard on aging is really innovative and will lead the country. It's very, very interesting. Very few states have even tackled this. Same thing on the early childhood side. We're really thinking broadly, right? Trauma, developmental index, and well-being indexes are being examined. And then, of course, student attendance and immunizations and all kinds of other registries can be merged into a data lake so that we have a better handle on how children are doing overall. That will influence the federal landscape as well.
Great, Kris. Kim?
Yeah, I would say, I mean, I think I've already mentioned the CMS money coming for home and community-based services and the caregiving infrastructure proposals. I would just lift up 2 others. I do think there is some more, well, I know there's more money coming for the aging networks and the disability networks, specifically the area agencies on aging and independent living centers. And so we're trying to use it as a capacity building moment. These networks have been, we're kind of set up in the Older Americans Act in the 70s and really have not kept up with the population at all. It's interesting, as older adults got moved into Medicaid with the Medicaid expansion in California, we had the CalFresh expansion. We had IHSS set up. We have all these kind of big county programs that now serve older adults, but the kind of classic senior programs are very thin. And there's really a kind of a capacity moment for us to think about that as we are getting more and more. I think we're in our 4th round of federal stimulus, how we yes, feed people who are immediately hungry right now and need record numbers of home delivered meals, but also look for those system leap forwards. We're looking at digital divide opportunities. And I would say something that I'm still noodling on and would love, and I know my colleagues are, and I'd love people's thinking on is, you know, every time there's a crisis, we do a one-off grant to the community-based groups. Oh, census, let's go do contracts one time for one thing with all the groups that are rooted in communities, whether it's ethnic or racial or rural or farm worker or LGBTQ. Let's do this one-time grant. Oh, it's time for voter registration. Let's do it again. Oh, it's wildfire season. Let's do it again. Oh, now it's vaccine. First it's COVID response, now it's vaccine. And I just think, when are we going to acknowledge that this is actually the most valuable and important part of our equity success, is an ongoing, sustainable, supportive relationship? So like, is there a way we build out our structure that's federal to state to in California County to the community, and we consider that leg as important as investing in an infrastructure way? And I mean everything from data systems to training to, but I just, I think I've been in state government 6 years, and I think about my 6th round of emergency grants to the racially and ethnic, you know, and I think maybe it's time to center that as the most important part to our success, and have the dollars and the structure and the authority reflect that value.
Really, really good point. Thank you. You know, we only have a couple more minutes, so I'd like to ask the last question, a leadership question, to you both. You know that we're a group of healthcare providers who are participating in a leadership program, and as you think about how effective you are in your positions right now, and your leadership positions, can you share either what the most important leadership skill or leadership lesson or insight that you might have had that really has helped you be effective in your organizations, in your position? Kris, do you want to give this a try?
Yeah, I mean, that's a really, thank you for the question. It's a really important question. And I think listening to parents has been incredibly valuable. I'm very honored every time we are able to convene parents during these difficult times, to hear directly from them about what the system, how the system is failing them and what they need it to do. So we are hearing directly from them. And I think listening is a gift. And then I'll say the lifting up team members. So you see my colleague here, Kim McCoy-Wade, and there are dozens, hundreds, thousands of other people in state service. Dr. Pfeiffer's on this call, I saw her. Phenomenal talent, phenomenal. And we're all over different parts of the administration, different parts of the state government. We're serving it to the greatest of our ability, and it's a real honor. But I think being a member of a team that is laser focused on equity, on racial equity, and making sure that while we're here, we do everything we can to build the system up to serve Californians better than we have before.
Great. Thank you, Kris. Kim.
Well, this has been a challenge for me because before COVID, my absolute rock solid was a day in the field every month. I had to go out and hear from people and see people. And with all respect to my team and my colleagues and my fabulous days of meetings and hearings, it is nothing like learning and recharging from being in front of people who you're here to serve. And so I have missed that terribly. Although I will say virtual has allowed us to bring in more stakeholders from places we wouldn't have otherwise, people with travel barriers for money or accessibility or other reasons. So I've got to hear more voices, but it's not the same as being in a nursing home, for sure. Where I have really gone deep, and this is partly working with older adults and partly my own personal passion, is history. If you are an older adult in this country right now, you were probably born during segregation. You were probably born when your marriage was not allowed if you were LGBTQ. You have lived through the HIV crisis. You may not have been allowed to vote when you were born. People, you may have been interred. I have people I work with who were as toddlers, were in internment camps. And so as hard as this past year is, reading their stories, hearing their stories, asking for more of their stories helps me keep perspective and remember that we can get through this. And in fact, we just are about to launch a project with the California State Library called California Chronicles to work with libraries to do intergenerational partnerships, Kris, to collect more stories from older Californians who have lived through change, to share their story, lived through hard times. And yeah, not all of it's going to be happy. Not all of it's going to be happy ending. I'm not okay yet. And I'm sure many of you on this call are not okay yet. It's been a tough time and we're still in it. But we do get through it. And the resilience of knowing our history, listening to our elders, spending time with young children, all of that is helping carry me through until I can get back with the people I'm here to serve.
Wow. Well, thank you so much. This was so valuable for me, and I think I speak for everyone, for all of us. Thank you for joining us this afternoon. And Renee, I'm gonna toss the ball back to you.